Hello everybody, thank you for tuning in for this session for Dr. Bolad Cardiology Clinic questions and answers live. I am here to answer your questions. I realize you are all on different time zones. Here in the States, it's early morning. In Europe and in Africa, it's afternoon. Middle East, it's evening. Far East, it's nighttime. And in Australia, it's actually Monday morning, over the early hours of Monday morning. So wherever you are tuning in, thank you very much for tuning in, and I'm here to answer all your questions. I have got a disclaimer here that I would like usually to show is that I am here to help you with all your questions and answers. This is to inform you about your heart disease and to enable you so you can go and ask your doctors about your condition, being armed by the information I provide you here. I'm not here to replace your physician or your healthcare provider wherever you are. I'm here to help you understand and be empowered, so to ask the information when you go and see your doctors or healthcare providers. So with that being said, let's get this session started. The questions, I received some questions already before this session from viewers, and I will share them, and I'm also going to obviously answer the questions which are live now. So with that being said, let's start with the first question, which is live here. So the first question is from Nazra. Can the plaque formation in the coronary artery be treated with medications only? Thank you for this question. It's a very good question, and it really depends on the extent of the blockage. So if the blockage is mild, yes, you can be treated just with medications only, and that's what we do in people who come to us. We know they have got coronary disease. Either we have done tests for them like cardiac catheterization, or have done CT, coronary angiograms. We put them on medications only, depending on the extent of their disease. General medications include like aspirin, include cholesterol lowering medications, usually of the statin group, and in addition to that, beta blocker medication to protect the heart. These are the general ones. However, as disease progresses, then the disease becomes more severe, and therefore at that time you will not have only medications to treat them. So if the narrowing goes to like 70% or more, meaning that it is going to affect the flow of blood to the muscle of the heart, then that point comes in which medications on their own are not going to help. Therefore, you will need something like either stent or bypass surgery, depending on the extent of the disease. So here is just like the picture I am showing you. So normal artery, when the buildup is so severe, as you can see on the right side of the screen, then you have to have procedures, either a stent or bypass surgery. Sometimes still you can control lots of the symptoms by medications only, but this is individualized. But initially, yes, medications can be the first source of treatment for these cases of blockages. So that's what I would say here in this case. Yes. Okay, I'm going to go through some of the questions that I received here. Mubam from Nigeria. What is the cause of sudden heartbeat and voice shaking which involves the body as well? What is the cure? Thank you, Mubam, for your question. So heartbeats, obviously when they are regular, generally you don't have symptoms for it. Basically, all of us, our hearts are beating and we don't have any symptoms. When there are some extra beats in the heart that originate either from the upper chambers of the heart or from the lower chambers of the heart, that's when we start having symptoms like extra beats, like palpitations, etc. And the treatment really depends on what is the cause for the palpitations. So this is a general heart, and our beats are usually between 60 and 100. So when we have an arrhythmia, and this can be one of so many different things, then you start getting the symptoms. The commonest are premature atrial contractions, and usually they are contractions occurring from the upper part of the heart. These are extra beats, which are not the normal rhythm here. So this is one type, and it's a common type of having extra beats. The other one is to have the extra beat originating from the lower part of the heart, and we call this premature ventricular contraction. And as you can see here in the tracing on the ECG on the left side of the screen, you can see that there is one normal beat followed by a broad abnormal beat. Slow heartbeat, obviously when your heartbeat is less than 60 per minute, your heartbeat should be between 60 and 100 beats per minute. Now, ventricular tachycardia is a more serious arrhythmia, and usually you will feel it, and it's because the lower part of the heart beats very fast, doesn't have time to fill, and therefore your blood pressure is likely to drop and something happens. So what happens in most of the people is just like 2 to 3 beats or so, or 4 beats, and stops. If this persists, it's a serious arrhythmia. Atrial fibrillation is a very common arrhythmia, and it affects more people in the older population. And by older, I say that like 70 people, 75 years and above, 10% of them will have extra beats in the heart. This atrial fibrillation. So atrial fibrillation occurs in about 10% of people 75 and above. So it's a very common arrhythmia, and it's an important arrhythmia because you can have clot formation in the heart, and these clots can go to different parts of the body and block the circulation. And we worry about it. If the clot goes to the brain, it will give rise to a stroke. That's why people who has atrial fibrillation, usually we put them on blood thinners to prevent the formation of these clots. Other arrhythmias is like atrial flutter and supraventricular tachycardia. These are also can give you the sensation of your heartbeat beating fast. Others include the blockage in the conduction from between the upper and lower part of the heart, and this usually you will feel symptoms with it, and you will need treatment. So to come back to your question here, these are the causes of the heartbeat. And you said the voice shaking, which involved the body. I suspect that it's the arrhythmia or these extra beats are persistent, and therefore you feel it, and that's why you feel the shaking. That's my suspicion here. What is the cure? The cure really depends on the cause of the symptoms. So with these extra beats, I suggest you check with your doctor and ask whether you would benefit from a heart monitor. And the heart monitor will give you a good idea about what are these beats and where they are originating from. And then the cure depends on it. In most cases, if they are not severe, usually we resort to beta blockers, something like atenolol or propranolol or carvedilol, and these generally control the symptoms. So this is what I would say about your condition, Mabam. Thank you. The next question is, okay, let me put it on the screen here. This is a question from Ankal Atri. What might be the reason for the second heart failure after stent surgery? I see that you have got also another question here. I think you follow two questions at a time. Actually, I have got a few ones. Let's start with your very first one and send it first. This is Ankal from India. My mother has undergone a heart stent surgery in November of 2021 due to blockage. Within next 8 months, she suffered from another heart failure. Doctor said there is a leakage in the heart valve. But doctor said no need for surgery. What might be the reason for the second heart failure after stent? Okay, so thank you very much for your question. It seems to me like there are two issues here, just from the questions that you mentioned. You said she has undergone surgery due to blockage. And this is obviously, that means that she had multiple blockages causing significant reduction of blood flow, and that's why they have she has undergone the surgery. This wasn't really something that they could treat with a stent. And then she went into heart failure, and then you have been told that there is a valve issue. So heart failure can be due to either to coronary artery disease, or it can be due to valve issues. I wonder what sort of valve issue does she have? I mean, wasn't it something that they knew before the surgery? Because if they knew this before the surgery, most commonly when they are doing the bypass for the blockage, then they do the valve surgery at the same time. Having said that, if it was mild or moderate, the valve issue, then they might opt not to operate or do the valve surgery at that time, because your own valves are always better than new valves that they are going to put in. So I suspect that was the case. They have done the blockages, they've done the bypass, and then after that she continued to have the heart failure, and then they said probably now there is the leakage. I suspect, and this is a general thing, it's usually a combination. Surgery does not cure the blockage 100%. So surgery bypasses the big arteries, and though usually there are small arteries that are not bypassable. So you will have some degree of what we call ischemia, reduction of blood flow to the muscle of the heart. That in combination with the valve issue might be causing it. Now, I don't know how old she is here, but that might be that might be the limiting factors, as they would not like to interfere again. I see that you also sent another one. Let me put it on the screen. She has not undergone major heart bypass surgery. She has a problem with diabetes and blood pressure for the past 8 or 10 years. I was just going on your first. Okay, I see. So she had a stent surgery in November. Stent, not open heart surgery. Okay. So there are, I suspect that with the stent and with the heart failure, that now the options are, if the valve issue is a major thing, then they can still go and fix it by surgery. Alternatively, in the current day and age, they can do lots of fixing of the valves percutaneously, meaning they do not need to open the chest to fix the valve. They can go from the leg usually, and either if it was the aortic valve, they can put a stent there. If it was the mitral valve, then they can always put in a suture to try to narrow the leakage. Do you know what sort of heart surgery he has had? I see that here you said that she is 55 years old. Okay, she is young, so she should be able to really tolerate any procedures that's going to make her better. 55 years of age is quite young for, so it's not really like a prohibitive age for any big surgery or anything like that. So I'm just showing you here, because you mentioned the valve. So the common valves that can get affected in heart failure is, first one is the mitral valve, which you can see on the right heart of the screen, which is between the left atrium and the left ventricle. That is one of the commonest valves that get affected, and usually with coronary artery disease, there is usually a leak. The other artery that gets affected is the aortic valve. It's also, you can see it here on the left side of the screen. Sorry, on the right side of the screen in the red area here. I don't know whether you can see my pointer. Mitral and aortic valve are the commonest valves to get affected in patients with coronary artery disease. So she had the stent, the heart stents done, so they opened the blockage, and now she still has got heart failure. So if it is due to a valve, then they should be able to fix it. Sometimes, if it is mild or moderate, medications on their own should be able to help. Oh, okay, I see. And since doctor tried to fix it with medications, okay, and then you said yes, it is a mitral valve, right? I mean, as I said, this is the commonest to be affected. Is the mitral valve in this condition. So medications on their own, they do work, and the reason being, we try not to do invasive procedures. If they work, they work. If they don't, that's when we go to the next step, and that's when it's either open heart surgery to replace the valve, or, as I mentioned, it can be a percutaneous option in which you go from the leg and you put a suture in the mitral valve to narrow the leakage, and therefore she most likely would not need invasive surgery, at least at this point. So she had the stents, so the arteries which were suspected to be the cause has been opened and revascularized, the blood flow has been restored, and therefore the valve issue is the next one. I just have also to say that, just to complete the story here, this is a very common condition that we get in people, especially patients with diabetes and diffuse disease. And I see that, I mean, that's what you said, that she has got a coronary artery disease and diabetes. So this is what I would say here for that. It's a common issue, and it should be most of the time be able to be treated with medications, and if it doesn't, then we go to the next stage. Thank you for your question. If you have any follow-up question, please type it, and I will share it and try to answer it, Mr. Anchal. Okay. So the next question is from Kerala in India. Single vessel disease, left circumflex total occlusion, done angioplasty without stent. Doctor said half block gone, but patient have no symptoms. What to do next and what are the precautions that are needed? So it's a single vessel disease, which is basically the occlusion of the circumflex coronary artery. Okay, so let me just try to share here some information here about the coronary circulation. So this is the coronary artery circulation, and what you are saying that it's single artery disease is the circumflex artery here, which is blocked. So usually with single coronary artery disease, if it cannot be opened easily, meaning that it's a chronic occlusion and it is causing issues, then medical therapy can a lot of time help. As you can see in this diagram, we have got like three main arteries. One is the right coronary artery from the right side of the heart, which is shown here on the left side of the screen. The other two arteries are the left anterior descending coming to the front of the heart, and the other one is the circumflex, and both of them originate from a trunk known as the left main coronary artery. As you can see here, left main coronary artery divides into the artery to the front, the left anterior descending, and the circumflex. And the circumflex artery is the artery which is blocked here, and doctor said just medications for it. It was total occlusion. They put in the angioplasty without a stent. So if it's just a blockage and it seems like, I understand, like it's half gone, might be like it's half open or part of the artery is open and part of the artery is not, then it, in most of the time, controlling with medications, provided that there are no symptoms and the patient can do the normal activities, and he said no symptoms, then that is not unreasonable. It is reasonable to continue just like that without pursuing aggressive treatment, like, for example, open heart surgery or putting more stents, etc. And it seems like, from what you're telling, ballooning only, that means that I suspect the artery is small, because in most cases we do put a stent when we relieve the blockage to prevent the artery from collapsing again. So we put a stent to keep the artery open, but this is not what happened here. That tells me that the artery is probably a small size, and that's what they have done. So it's quite reasonable to continue on medications only at this time, provided the patient has got no symptoms. So this is a reasonable thing, and I would tend to concur with that. You are welcome. Someone here. You are welcome. I'm happy to help. If you have got any questions, please feel free to send it to me anytime. Daniel from Ghana, why do I have heart pains? So this, there are so many causes for heart pain and for chest pain, and it depends really what is the cause for the heart pain in the first place, in the first instance. So let me try to see if I can provide you with some information here regarding chest pains and heart pains. So this is just like an overview. I'm going to give you just like an overview. There are serious causes for heart pain. One of them is obviously angina and heart attacks, and that is due to blockage of the coronary arteries. and these are the most serious. The symptoms are very severe and they come on suddenly, and chest discomfort, lightheadedness, pain in the jaw, pain radiating to the left arms are the most important manifestations of this type of pain. If this type of pain is there, you need to report immediately to your emergency room to be evaluated. So these are the, I'm going through the life-threatening ones first. Aortic dissection is another life-threatening cause for chest pain, and that is basically the aorta, as you can see it here in the diagram. The inner layer separates from the middle layer and becomes a flap. And the problem is that when it extends, it starts to occlude the flow, the organ to the arteries, to the other parts of the body. Aortic dissection. Pulmonary embolus, when a clot goes from the right side and lodges into the lungs, and this can be a life-threatening condition if the blockage is significant and severe, because it just blocks the circulation in the body, and therefore this is also an emergency and it needs immediate treatment. Pneumothorax is another one. Basically the lung collapses and it does not inflate every time you take the breath in, and air tends to accumulate between the chest wall and the lung and push it, and depends on the severity, this can also be a very serious condition. Inflammation of the mediastinum is where the heart sits, is an uncommon cause, but if it happens, it's a serious manifestation. Pericarditis, inflammation of the covering of the heart, is another cause for chest pain, and this can lead to fluid accumulation, and the fluid can be so severe so that it compresses the heart, and it can cause significant hemodynamic compromise. So these are the life-threatening ones. The non-life-threatening ones include, like, if you've got shortness of breath, that will give you can sometimes give you chest pain if you have got underlying coronary artery disease or if you have got valve disease. Uncommon causes, but it can happen. Pericarditis, I just spoke about it. That's the lining of the heart, as you can see here. If it gets inflamed, then this can be a very serious condition, and it needs treatment with anti-inflammatory medications. And the risk is that with the inflammation, fluid can tend to accumulate in the sac, and that can cause compression of the heart. So this is another cause for chest pain. Inflammation of the muscle of the heart can also give rise to these pains, and therefore if that is occurred and it's a cause, then all of that needs to be treated depending on the cause of the inflammation. Lung causes, we spoke about clots in the lung, but also if pneumonia and other inflammatory conditions in the lung can also cause that. Inflammation of the lining of the lung can also give rise to chest pains. If you have got reflux from the stomach, so acid reflux back to the esophagus, this can also give rise to chest pain. If there is got a sliding hernia from the stomach, also pain can be coming from the muscles and from the bones of the chest, and this can give rise to chest pain. And sometimes also panic attacks tend to give rise to them. So this is really like the general overview. So the causes are so many for anyone to have chest pain. Importantly, the most important ones, I outlined the first ones, like blockage of the coronary arteries, angina, heart attack, pulmonary embolism, pneumothorax, mediastinitis. These are important ones. If this pain is there, I would suggest that you check with your doctor to be evaluated as to the cause of the chest pain, and try to evaluate and see what is happening. And to try to treat it, obviously. Okay. A question here from the United States. What does it mean to have a nerve pain in your chest? So for the nerve pain, it's all pains are from nerves because that's how it's conducted. But I suspect from your question, you're talking about it's not coming from the heart. That's what I get from this question. What do you mean by nerve pain? So I suspect that if your doctor examined you and he or she has ruled out that there are non-serious causes and it's mainly from the chest wall and it was due to a nerve distribution, that's what they mean by nerve pain. But all pains generally are conducted through nerves. That's how you feel it. So the nerve pain is, I suspect from your description here, is that it's a superficial pain on the chest wall, and that is the cause of the pain. That's what I suspect just from your question here. A question from England. I struggle with palpitations. They come suddenly and last a few minutes, and I try breathing exercises to calm down, but they scare me. I had an ECG and a heart monitor for 48 hours, but it did not show anything as I did not have symptoms at the time. My palpitations will be every 6 weeks or more. Please give me an advice. Thank you for this question. I'm not surprised that they did not catch it on the 48-hour monitor, because you said the symptoms for the palpitations occur once every 6 weeks or even more. So this is not going to show on the 48-hour. You'll be very lucky for it to show there. So for palpitations that occur that infrequently, we need to have a longer monitoring period. There are different devices that we can put that can help you. Let me try to see if I can show you some of the devices that we put in, and then we can I can explain to you about what is needed here. Let me see here. Trying to find out from my database whether I have got pictures for you so I can help you understand. I think it's always better for me to show the pictures so that you can understand what it is. So just bear with me for a second. Heart monitors. Here's our loading. So here is what I'm talking to you about. So you said yours occur every 6 weeks or so. So what you have done is, or what your doctor has done, is monitoring for the 24 hours or 48 hours on the left side of this slide. And that's only for very short period of time. For longer periods of time, you need other devices in order to help you, like event monitors and outpatient telemetry, medical continuous patient telemetry. These are the two that I think that you would benefit more rather than from the just from the 48-hour Holter monitor, because these are unlikely to show you much here. So what you had is something like this for 24 or 48 hours. However, for what you are describing, you will need possibly a ZU patch, which is like a monitor that's put on the chest, and that usually records for up to 14 days, and after that it's sent for analysis, and then we can figure out what the abnormality is, because your heartbeat has been recorded for 14 days. So this is one option. The other option here would be what we call the mobile cardiac outpatient telemetry units, MCOT, and that's basically similar to the patch I just showed you. It's put on the chest, but this is continuously monitoring you and transmitting to a center who continuously monitor your heartbeat, and then they will be able to evaluate at any time, at any point in time something goes wrong. They will call you, or they'll call your doctor, informing them that something abnormal has been noted in the recording, and that would definitely, very likely in your case, is going to catch it. It goes for 1 month but can be renewed to a second month, etc. Just for completion sake, and I don't think that you will need this, is that sometimes we do implant some devices in the heart in order to in the outer chest wall. It's a very simple procedure. What you call implantable loop recorders. You can see it here is a green on the left side, on the right side of the screen. That's just under the skin, and that will keep recording your heartbeat continuously. This device can be for a year, for 2 or 3, and you can just put like a transducer up on top of it, and you will get lots of the information regarding your heartbeat. I don't think you need that, but I'm just mentioning it. This is like options for people whose symptoms actually occur every 6 months or every year, and they can be quite significant, and we cannot find out the cause. So we resort to these sorts of monitors in order to try to figure out what is wrong with the patient and try to help them. So there are options. The 48-hour monitor did not get it for you. I totally understand it, because your symptoms occur every 6 weeks, and you would have been lucky to get that in the 48 hours. But definitely something like the ZU patch, which I showed you, or something like the outpatient telemetry one, which records for a month continuously, are very likely are going to get or find out what the problem is in your case in order to help you. So I hope that you find that this is informative, so you can go to your doctor and discuss whether you need a ZU patch or an MCOT in order to evaluate the cause for your symptoms here. A question from Canada. My left arm is tingling, and sometimes I wake up like my heart is squeezing. What should I do? Well, I tell you, with these symptoms, you should really report immediately or as soon as possible to your doctors. Tingling, my heart is squeezing. This needs to be investigated. You cannot just ignore these symptoms, because obviously we worry about significant coronary artery disease. So I would say that you go to your doctor and immediately, or even to the emergency room, to have a quick checkup on you, and then if they don't think there is anything serious with you, then they can refer you to your cardiologist to do further evaluation, or whoever they think is the appropriate physician for your symptoms. But I think you shouldn't be really ignoring these symptoms, because these symptoms are quite significant, and the worry here that there can be a manifestation of significant blockage in the coronary arteries. Therefore, I recommend that you go and you get checked as soon as possible. Yeah. question from Ghana. Most of my ECGs report T-wave inversion and a cardiologist comment indicating ischemic heart disease from 2020 to present. I live a normal life with no symptoms of heart disease. I did an echo in 2021 and it is reported that everything was perfect and no ischemia. My current ECG was in January of 2023 and it also indicated T-wave abnormality. Please help me out to change this. Is it lifestyle or medication to correct the abnormality? Thank you. Well, thank you very much for your question. We have got variants of a normal ECG. I don't know when you said everything was normal. You said an echo was done, and echo would not exclude significant causes of, for example, ischemic heart disease. As you mentioned, your cardiologist stated that that was inversion, cardiac comment indicating to present. So some people have got these changes not only due to coronary artery disease, but also due to their cardiac structure. And we find this more commonly in people of African origin. So it can be like a normal manifestation for you. However, I would not label it as normal unless you had significant tests or to rule out significant blockage in the coronary arteries. I know you said you had no symptoms, but when we find an ECG like this, usually we go all the way, including sometimes doing cardiac catheterization to make sure that there is no blockage in the coronary arteries. In this day and age, we have got other tools like CT coronary angiogram. You don't even need an invasive test like a cardiac catheterization. It can be referred. I suspect you will find this in Ghana as well. Other thing is to do a stress test to see how these changes are. So you have to do this first to exclude coronary artery disease. If that has been excluded, then you can label it that this is your normal variant. Some people have got abnormalities in the muscles themselves, and this can cause these structural changes of T-wave abnormality. I know you said that the echo is normal, and that's important because the first thing is that the echo to show significant blockages. There are some hereditary and genetic diseases that can be quite serious, and this can be diagnosed by an echocardiogram. The next step after ruling out coronary disease, which I mentioned how you have to go about it, and the echo is normal, is to do what we call a cardiac MRI, cardiac magnetic resonance imaging. And this would tell us if there is structural abnormality in the muscle of the heart. Please help me to change this. I don't think it's going to change like that. I think this is something that you were born with and start to develop. The first ECG you said was done in 2020, and you have done in 2021 now. But I think this is something that you had for some time. The important thing is that we need to figure out what is the cause for it. If you couldn't find the cause, the serious causes, if you couldn't find the serious causes, then that's good. We just a matter of observation for you. It will not change unless there is a reversible cause like blockage of the coronary arteries, and then we reverse it, and then the changes are going to revert back to normal. So I hope that you find that helpful. Let me see here. Okay, this question is from Lagos, Nigeria. I have constant chest pain and an ECG shows that I have incomplete right bundle branch block. Most time it feels I can't breathe well and blood is not flowing well. What should I do? I think you should be checked with this. It's right bundle branch block can occur in about 5% of the population and can be a normal finding. So just a right bundle branch block found on routine examination can be a normal finding. However, here you have constant chest pain and incomplete right bundle branch block. Things that spring to mind is that either you have got some degree of coronary artery disease causing this, or maybe clots in the lung, because clots in the lung can obstruct flow to the lung and can cause pressure on the right side of the heart, and sometimes they can cause right bundle branch block, incomplete right bundle branch block. And you also mentioned I can't breathe well. So putting all this together, I would ask that you go and get investigated, because either coronary disease or clots in the lungs, these need to be ruled out. So this is things that you need to rule out before we can make any decisions. So I would please advise that you go to your doctor and ask to get checked with that, so that the cause can be found out. I know that you said incomplete right bundle branch block, therefore you have seen your doctor, but I don't know what he told you. He didn't mention about what was said to you. So these are the things that I would say that have to be ruled out: coronary artery disease and pulmonary embolism, clots in the circulation of the lung. Okay, a question from Rita from Ghana. I have been in Saudi Arabia for 10 months now. I have this chest pain. I have been in hospital, but still I am in pain when I touch my chest. Please help me. Thank you for your question, Rita. So I don't know what they found out. If you can elaborate more what they told you about the chest pain that you have, and they are still there. But one fact that you said that you have this pain when you touch your chest is telling me that it might still be something not related to the heart. But I can't, just with the information you provided me, I can't really rule it out. The important things, and I don't know whether you were here for the first part of this presentation, I spoke about, someone else asked about chest pains, and I did go through the causes here. So I'm going to share this here with you briefly, just to go through them again briefly with you here. So musculoskeletal chest pain, and that's what you are describing. You described that you have got the pain in your chest when you touch your chest wall. So it is possible. Gastrointestinal cause doesn't seem to be in your case, because it's reproducible by touching the chest pain. Lung causes like pleurisy, it is possible that you might be having this on and off. Now I would go to show you now the serious ones briefly that I already spoke about in this presentation, but these are the ones that we always worry about and we try really to rule out as soon as possible. Obviously, pain coming from the coronary arteries giving rise to angina or to heart attack, these are very important ones that need to be ruled out. Aortic dissection, that is separation of the inner and the middle layers of the aorta. This is a very serious one. You don't seem to be having it because it has been going on for 10 months. If you had this, you would have manifest and you would have been treated very early for it. Clots in the lung, pulmonary embolism. This is another cause for the chest pains, serious chest pains. Pneumothorax, meaning that your lung has collapsed a bit, and therefore part of the lung does not expand as much as it should do. inflammation of the mediastinum, which is the middle part in the chest, and this is if it gets inflamed, therefore can give rise to significant symptoms. Pericarditis is another one that I would say here for you. So the pericarditis here, and that's basically inflammation of the covering of the heart. Myocarditis, inflammation of the muscle of the heart. That doesn't seem to be you because this has been going on for 10 months, as you said. And obviously spoke about the issues regarding the covering of the heart. So these are the general causes here that I would say. If you touch it, it's mostly musculoskeletal, but all the other important causes will need to be ruled out. So this is what I would say. I wonder whether they go away with simple painkillers or not, and I wonder whether your doctor has excluded all the serious conditions that I just mentioned here that they need to be ruled out. So this is an important thing that I would say, and that's what I would advise you. So, a question from Ethiopia. I have high blood pressure, 145/95, pain around the center of my chest. I've got sleep apnea, swelling of the lower leg. I am taking medications, Amlo. I suspect this is amlodipine, and Concor in the evening, and 81 milligram of aspirin. I am 50 years old and I smoke 10 cigarettes per day. How do you help me to improve my heart condition and remedy for the swelling of the legs? This happens 2 weeks ago. In addition to the swelling, you also mentioned you have got chest pain, sleep apnea, swelling in the leg. So how can you help me improve my heart condition? You mentioned here that you are a smoker, you smoke 10 cigarettes per day. And obviously the first thing, and probably lots of people also told you, in order to help your heart condition, you will need to stop smoking. This is the one thing you can help yourself with. You said you're 50 years old. So you're young, you're middle-aged. So things build up as you smoke, blockages occur everywhere in the body, including the arteries of the heart. So one thing really I would advise you is to stop smoking in order to help or reduce any blockage that has already occurred. You mentioned important symptoms, and your doctor put you on medications which lower blood pressure and can also be for heart or coronary disease, blocking the coronary artery. I wonder whether any investigations have been done to you regarding these symptoms that you're having, like chest pain. So this will need to be ruled out that you have got coronary disease, especially that you are a smoker. The likelihood of you, the risk of you or likelihood of you having coronary disease is high, and therefore this needs to be ruled out. First, probably with a stress test, and if that doesn't show, then you can go to invasive tests, either like cardiac catheterization, that's what we use, or non-invasive tests. Sometimes we use CT coronary angiogram, and that can give us a good idea. The swelling of your legs can be due to one of two things from what you mentioned. You mentioned sleep apnea. Sleep apnea can tend to affect the right side of the heart, and that can cause to swelling in the legs because of back pressure. That can lead to that. So this can be a cause. The second one, with you explaining to me regarding your chest pain, it can be related to coronary artery disease. So this needs to be evaluated. Probably your doctor, I would ask you to check with your doctor with this swelling. I was going to give you as a start like water medication to try to get rid of the fluid, but the cause for this will need to be evaluated. So you need to check regardless if you have got coronary artery disease or whether it is sleep apnea. You did not mention that you had an echocardiogram or anything like that, because an echocardiogram would tell us whether there is increased pressure on the right side of the heart from the sleep apnea causing that. Would tell us about the overall function of the heart and the valves. So an echocardiogram, which is an ultrasound scan of the heart, would give us a lot of information. So I suggest that you also discuss that with your doctor. I think that from the information you provided me, you still need much more tests to try to figure out about what is the cause of your symptom, especially the chest pain, and you are being a smoker. That will need to be evaluated, so please check with your doctor as soon as possible so we can find out the cause. A question from Nigeria. I have palpitations. I have done an echo test, ECG, and I'm told everything is fine. I also have high cholesterol and high blood pressure. What can I do about this? So for the palpitations, the reason for the palpitations will need to be evaluated, basically to find out what is causing it. This can be done if these palpitations are regular by a 24-hour monitor that we did discuss earlier in this presentation regarding another viewer who asked about it. There is a 24 to 48 hours monitor, and there is the ones that you can put in that can go on for 2 weeks, and the ones can go on for 1 month. So if they are frequent, you might just need the 24 to 48 hours ones, and that would tell us about the cause of the palpitations. So this will need to be investigated and found out. The echo tell us about the function of the heart and whether there are leaky valves, etc. So it wouldn't really tell us the cause of the palpitations. Sometimes it does, but this is not the test for palpitations. The test for the palpitations are the heart monitors. ECG, if you have done the ECG at a time in which you did not have the palpitations, it's not going to show the cause. In addition, you said you have got high cholesterol and high blood pressure. Obviously, this will need to be treated. I don't know how old are you and what other risk factors you have, but definitely the high blood pressure will need to be treated. High blood pressure, other name for it is the silent killer. So you don't feel it until so much damage has occurred in the body. So if you now know you have got high blood pressure, then I suggest that you get treated, and your doctor should put you on some medications. With the high blood pressure, if you have got high cholesterol, that would also need to be treated. So this is what I would say here in your case. You need more investigations for the palpitations. Other cause has to be ruled out. You have got high blood pressure, high blood pressure and high cholesterol, and this will need to be treated. I've got one question that just came 2 minutes ago. Hello, doctor. This is Barka Ali from Singapore. My father had bypass CABG 13 years ago. Would you recommend me to take a CT angiogram for myself when I turn 40, just to be safe? Thank you very much for your message here. If your father had bypass surgery, therefore you have got coronary, increased risk of coronary disease. It doesn't mean that you have in particular. and you just mentioned that you are 40 years of age. I don't think that you need a CT coronary angiogram at this time. What you need is, for you, obviously, the risk factors that contribute to coronary disease should be controlled. If you are a smoker, then you should stop smoking. Your blood pressure should be controlled. Your cholesterol will be controlled, etc. Because irrespective, if you don't have symptoms, nothing is going to be done. But you need to be careful that blood pressure is controlled, cholesterol is controlled, etc. Because these are important things to prevent progression of coronary artery disease. In addition, if you get any symptoms, then you need to do a stress test. Which is basically either you be put on a treadmill and you run, or you give you medications to speed your heart rate, and we do either an echo evaluation or a nuclear test evaluation. The reason, Mr. Barakas, that we don't recommend CT angiogram for everyone, because CT has got radiation. So I'm exposing you to the risk of radiation. If you don't have symptoms, then I would agree that this is not advisable. Why would I expose anyone to radiation if they don't have symptoms? You heard me talking about CT angiogram here for a few of my viewers here, but that's because they have symptoms and something had to be done. Even if they have cardiac catheterization is also, they are also going to be exposed to radiation. So the alternative, which is less invasive, would be a CT coronary angiogram for them. So that's why I wouldn't say go have a CT coronary angiogram. But we can fairly control your symptoms, put you on the right medications, and if you get any symptoms, then you need to be investigated like a treadmill, or have a low threshold at that time to do a CT coronary angiogram. So that is what I would say. Certainly, because you have got a family history of coronary artery disease, you are generally at an increased risk of developing it. So this is very good of you. You are thinking ahead that you are at an increased risk, and therefore you have to be careful to control the risks and to try to prevent progression if coronary disease starts to develop. I hope this answered your question. Barakat Ali from Singapore. Okay, everyone, it's after 10 o'clock, and I don't see any more questions here on the list. So with that being said, I would like to thank you for tuning in to Dr. Bolad Cardiology from all over the world. Barakat Ali, it must be very late at night in Singapore. Thank you for tuning in. Please, if you have got any questions, you can follow up through my website or YouTube, and you can just ask me any question, and I'm here to help you and answer your questions all the time. That being said, I would say thank you and goodbye, and speak to you soon. Thank you very much.